All right. Uh, Hello, everybody. I'm Christina. I'm one of the STAR Chief Residents for Research, and welcome to our Resident Research Day. So today is our annual event to celebrate our internal medicine residents' research endeavors. It's no easy task to balance rigorous clinical training with our great research work, but our residents continue to go above and beyond. We're very excited to have the opportunity to celebrate their work and the mentorship by incredible faculty who have helped make today possible. So after grand rounds today, Resident Research Day continues during our posted session from 4 to 6 p.m. in the Emory School of Medicine lobby. But we're also going to give out awards for original research and clinical vignette posters. So please come stop by, get some food, and see our residents' tremendous scholarly output of over 100 posters. So now on to our talks. I'll introduce our keynote speaker, selected by our Resident Research Day Committee, Dr. Siva Bhavani. And after his talk, I'll introduce our three resident speakers. And we'll be saving all questions for a Q&A at the end. So first, very excited to introduce Dr. Bhavani. He's an assistant professor of medicine in the Division of Pulmonary and Critical Medicine. He completed his internal medicine residency at Baylor College of Medicine. And then he went on to the University of Chicago for his pulmonary and critical care fellowship, where he also completed a T32 research fellowship in Masters of Science in Public Health. So Dr. Bhavani's research is on the use of artificial intelligence, or AI, to guide a precision medicine approach to sepsis and other critical care syndromes. His vision is to translate the machine learning algorithms developed in his lab from paper to practice, and ultimately to improve the outcomes of critically ill patients. Through his K23, he has developed the vitals trajectory subphenotypes, an algorithm that guides crystalloid food resuscitation in patients with sepsis. This algorithm is being implemented in the Emory Healthcare System electronic medical record to prospectively study whether the algorithm can help reduce mortality in sepsis. The rapid development and implementation of AI has been an increasingly prominent aspect of our daily lives. And so we selected Dr. Bhavani for our Resident Research Day talk, not only because of his unique, innovative work, but also because we hope it inspires our residents to creatively utilize novel technology for the health and benefit of our patients. So we really look forward to Dr. Bhavani's talk, From Antiquity to Big Data, A Vital History of Body Temperature.
Great. Well, thank you, everyone. Thanks for that kind introduction. So it's an honor to present. I'll be presenting From Antiquity to Big Data, A Vital History of Body Temperature. I chose temperature as the theme for the talk because as a physician scientist, I started my research journey studying body temperature. So I want to share some of the research and the lessons that I've learned along the way. So these concepts of body temperature, fever have been around for all of recorded history. And for most of that history, we measure temperature subjectively by the feel of a person's skin. It wasn't until this, I thought it would go next. Okay. It wasn't until the 1600s where we actually had the advent of clinical thermometers. So the picture you see here is one of the first oral thermometers. And what you see is this several foot long tube with this huge bulb at the end that goes deep into your mouth. And it stays there for 10 minutes to get your temperature measured. So needless to say, this wasn't something that caught on clinically right away. And research into temperature didn't really get started until the 1800s. And a lot of it was work by this man, Dr. Karl Wunderlich. So Dr. Wunderlich was a German physician, and his life's work on temperature culminated in this book, On the Temperature and Diseases, which was published in 1868. So this is the book where we kind of get a lot of the temperature foundations from. And this is where he defined normal body temperature. This book is where he defined the daily variation in temperature. And this book is where he defines a fever. And so from a line in this book comes one of the most famous numbers in modern medicine, 38 degrees Celsius. So this is the number that kind of compels us to order blood cultures. It's part of SIRS criteria. It's part of sepsis alerts. And it's sort of surprising that this hugely important number comes from one line in one book written way back in 1868. But I would actually argue that this is not unique to body temperature. I actually think a lot of modern medicine may have this type of foundation where a lot of it is propagated and it's based on potentially antiquated data, a lot of the definitions we use. And so when I started clinical research, one of the first things I learned, one of the first lessons I learned was to question definitions. to question cutoffs, question thresholds. As physicians, we need these definitions in order to categorize and treat our patients. As an ICU physician, I need to define that my patient has sepsis or define that they don't have sepsis in order to figure out the next steps in management. I can't be in this nebulous middle ground. But as scientists, we can embrace this uncertainty. We can embrace the continuum of biological complexity. For instance, sepsis lies on a spectrum. Host responses to an infection lies on the spectrum. And at some point in this continuum, we have to draw an artificial line in the sand and call one side of it sepsis and the other side not sepsis. And so as physicians, we need that artificial line in the sand in order to do our daily activities and take care of our patients. But as scientists, we have this opportunity to question these definitions with the goal of refining the way we classify health and disease. So as a pulmonary critical care fellow at the University of Chicago, I was interested in questioning the definition of fever. In the ICU, we see patients with sepsis all the time, and patients with sepsis don't necessarily present with a fever. And their temperature is not a static measurement. It's kind of changes over hours to days. This is a patient with sepsis and their temperature measurements over the course of a couple days. And as you can see, there's a lot of rich longitudinal temperature data here, but they don't meet our clinical definition for fever. So all of this data goes to waste in clinical practice. So the question I had in fellowship is, how do we use this rich longitudinal temperature data to actually identify temperature patterns that these patients are following? And what can those temperature patterns tell us about our patients? And so this led to our work where we identified that patients with sepsis follow 4 general patterns of temperature. And these temperature patterns are predictive of whether they'll need ICU care, whether they'll require mechanical ventilation, and predictive of survival. And our work has subsequently been replicated in multiple cohorts at different institutions and also replicated by many independent lab groups as well. But for me, the most exciting thing about this temperature work is taking a measurement that's been around for 400 years and looking for hidden patterns that we didn't know about before. But this concept of temperature patterns or temperature trajectories, fever curves, it's not a new concept. It's an age-old concept. It's been in the literature for decades. But what's new is that we had access to 1 million temperature measurements from tens of thousands of patients, and we had access to machine learning tools that could make sense of all that data. So when you have an old question like temperature patterns, fever curves, but you can combine it with big data and novel computational tools, this could lead to new discoveries. And so the lesson I want to share here is that it's from a quote: if you want a new idea, read an old book, because just like temperature patterns are an old idea, there's lots of old ideas out there in the medical literature. And the archives of the medical literature are filled with thousands of unanswered questions, thousands of untested hypotheses. And we actually have this exciting and unprecedented opportunity where we have the data at our hands to go back and have a fresh new look at some of these age-old questions. So I finished my fellowship in 2020, and I had completed my master's of science, and I'd spent 2 years studying temperature trajectories. And at this point, I knew I wanted to be a physician scientist. And this wasn't something I had considered in medical school, residency, or even in the beginning of fellowship. So it really did take that 2 years of dedicated time for me to make that decision that this is what I wanted to do. And I bring this up because I think it takes dedicated time to rule in or to rule out research. And I think it's really hard as residents with a month of research to decide how big of a role you want that to play in your career. So for anyone who's interested in research, I would suggest seeking out dedicated time, which is easier said than done, but through a fellowship, through a faculty position, figuring out how you can get that dedicated time where you can actually rule in or rule out research as a big part of your career. So when I joined Emory faculty in July 2020, I was working in the COVID ICU. And I was at the COVID ICU at Emory Midtown. And so on my clinical weeks, I would be seeing patients with COVID-19 day in and day out. And on my research weeks, I was interested in applying our temperature trajectory algorithm to patients with COVID-19. But the algorithm didn't work. So this algorithm that I showed the slide before, where it worked in all these other cohorts, all these other institutions, wasn't working in this data set. So I knew there had to be something fundamentally different about this data. And what we found was fundamentally different was the use of temporal artery thermometers. And when we excluded these measurements and just focused on oral measurements, the algorithm worked again. So for the purposes of the research, that's what we did. But we kind of kept circling back to why it would be that temporal thermometers would either throw off the algorithm or skew the data in this data set. And around the same time, the literature was emerging about the racial bias in pulse oximeters, the finding that pulse oximeters are not as accurate in Black patients. And pulse oximeters are a type of infrared technology. Temporal thermometers are a type of infrared technology. So the question emerged, is there some shared mechanism here that could explain what we had seen with our data? And so this led to our paper, Racial Differences in Detection of Fever, using temporal versus oral temperature measurements in hospitalized patients. I'm not a health disparities researcher, so this work would not have been possible without my co-author Zanthia Wiley and senior author Igo Fodakun. But our finding was this: in white patients, it doesn't matter whether you use a temporal thermometer or an oral thermometer, you get the same measurement. But in Black patients, temporal thermometers miss almost 1 in 4 fevers that are caught by oral thermometers. I want to circle back to that quote I had shown earlier about if you want a new idea, read an old book, because skin color bias in technology is not a new idea. It's a really old idea. It's been around for decades. And if you go down the PubMed rabbit hole, you'll find a paper from 1964 where the authors cautioned that the pulse oximeter is designed for use on white skin. Its application to darker skin will obviously raise special problems. 60 years later, we are finally confronting these problems. And part of the reason it took 60 years is social change. But the other part of the reason it took 60 years is data. The fact that now we have 100,000 pulse oximeter measurements at our fingertips that we can look at and quantify this bias and kind of just show what this data shows. And so, the lesson I've learned here is that big data can uncover hidden biases. And for me, this has been a powerful lesson in research because that means, again, we have this huge opportunity to go back and take a critical look at all of our clinical practices, all of our measurement tools, all of our scoring systems to make sure that they're working for all of our patients. So one of the themes that emerges in my research is common measurements like temperature. What are the measurements that we check on every patient in every hospital around the world? And we don't think about that much at Emory because this is a huge academic institution. We can order whatever lab or whatever biomarker that we want to. We can order whatever imaging study that we want to. But for much of the world, this really isn't the case. And so, but I know that no matter what hospital I walk into anywhere in the world, the patient that I see is going to have a temperature, a heart rate, respiratory rate, and blood pressure measurement. And so that's part of the reason why I've been obsessed with vital signs, because if we can use big data to find the hidden patterns in vital signs, that can actually impact care for patients around the world, not just at certain academic institutions that can, have the resources to incorporate it. And I want to take a step back and talk about what is the point of looking for hidden patterns, or what's the goal of looking for hidden patterns. And the goal is to map these patterns to individualized treatment strategies. And so a patient with vitals pattern A might benefit from treatment A, and a patient with vitals pattern B might benefit from treatment B. So using vital signs as a way to enable precision medicine in critical care, and that would be the goal. And so with that goal in mind, what we found was that patients with sepsis follow 4 distinct patterns of vital signs. And we call these patients following these distinct vital sign patterns group A, B, C, and D. And these groups have different clinical characteristics and different outcomes, but aligned with the goal of precision medicine, these groups respond differently to different treatments. And what we found was that group D has a 15% reduction in mortality from balanced crystalloids compared to normal saline. Now, this question of balanced crystalloids or normal saline, which fluid is better, has been going on for decades, and these fluids have been around for more than 100 years. And for the average patient, it probably doesn't matter which fluid you use. But for this group of patient, it seems to have a mortality difference. And so this finding led to us getting funding from Kaiser Permanente and the Gordon and Betty Moore Foundation to actually test this in a prospective trial. So that's the basis of the PRECISE trial, precision resuscitation with crystalloids and sepsis. I know I've spoken at other resident lectures about this and gotten feedback on the algorithm itself and how it's going to look to people who see it so that they're not annoyed by a pop-up, in Epic. But this is in this trial, the algorithm is running in the background of Epic, and it's using vital signs to identify patients who are group D, and then randomize them into usual care versus intervention, with the intervention being a nudge trying to get them the right type of fluids. And I'm really excited about this trial because this is one of the first clinical trials of an AI algorithm in critical care. And this is the first time we're having an algorithm go from paper to practice. And the whole goal of research is to make that slow progress towards actually impacting and improving patient care. But if you asked me a year ago whether I could run a clinical trial, my answer would have been no, because I would have no idea where to start. And that's because the PRECISE trial and trials like this are a huge collaborative team effort. So it's a huge team effort from people across the Emory ecosystem, including the Emory Critical Care Center, our division, Pulmonary and Critical Care, Emergency Medicine, the Emory Digital Office, Biomedical Informatics, and Georgia CTSA. And so it's taken mentors, advisors, and collaborators from all across Emory. People like Craig Cooper-Smith, who's my mentor and the director of the Emory Critical Care Center. Greg Martin, our division chief, who initiated the conversations about this funding mechanism. People like Colleen Kraft and Jason Atkins, who connected me with the technical team to actually incorporate the algorithm into Epic. And so the lesson I want to share here is that big projects require big teams. And the reason a year ago I would have no idea where to start is because I didn't have a team of experts who could fill in my gaps of knowledge and connect me with the right stakeholders. So if you're ever feeling stuck in a project, the question might not be, what do I do next, but it might be, who do I bring on to the team next? All right, I want to spend the last bit of time talking about the best thing and the hardest thing about research. And I'll start with the hardest thing. And the hardest thing is rejection. Obviously, for the purposes of a presentation, I'm going to cherry pick the 3 successes that I've had. But it comes in the background of hundreds of rejections. And this is rejections in terms of manuscripts, grants, and like intangible things that like projects that just didn't go anywhere. So the research often feels like just a string of failures and rejections punctuated by like an occasional success. And so the question is, how do you normalize this process where it's mostly rejections? And what I found to be helpful is to aim for a rejection rate, because you don't want a 0% rejection rate. Because a 0% rejection rate suggests that you're not putting yourself out there enough, you're waiting too long to get that idea going or that project going because you're afraid of that rejection. So you want to aim for some number of rejections per month or per whatever period of time seems appropriate. But and it's fun. Well, it's not funny. It's kind of ironic, but a couple of days after I made these slides, I actually got the biggest rejection I've gotten from the NIH on the biggest grant that I've submitted. And so what did I do in response? I argued with the reviewers over all of their comments. I pointed out to the reviewers all the things that they missed about my grant. And I pointed out to the reviewers all the things that they got wrong about my grant. And I did all this in the one place where I always win my arguments, which is to say I obviously didn't do any of that. So what am I actually going to do in response to this rejection? I'm going to say thank you for those insightful comments. And this is how we've changed the grant in response to these comments. And I would say that's probably the hardest thing about research. The best thing about research is the flexibility. And this is flexibility in the hours that you work and what you work on during those hours. And this flexibility has been amazing for our family. We have 2 young kids, and it's just amazing to be able to schedule my hours on research around them. And the flexibility doesn't mean you work less hours, because a lot of times on my research weeks, I end up working more hours than my clinical weeks. But you get to distribute those hours around family and other priorities. And the other thing is just the intellectual flexibility, the fact that you can decide what you want to work on a day-to-day basis, what you want to focus on, what you want to read, write, learn about. That's been something that's been amazing to me. And I think anyone who's very self-directed and kind of likes having that flexibility would enjoy that about research. I want to end with a story about my son, Deva, who's pictured here doing a well-child visit for our daughter, Veda. Deva is going to be 5 next month. And unfortunately, he's figured out that if you're sick, you don't have to go to school. So every couple of weeks, he wakes up and pretends to be sick so he can get out of his, the brutal academics of pre-K. And a couple of weeks ago, he did that. He woke up and he said, "Dad, I'm sick. I can't go to school today." He wasn't coughing, no sneezing, no diarrhea. Poor historian. And so I did what all of us do in this circumstance. I checked his temperature. And his temperature was a healthy 98.5. So I told him, "Deva, you're not sick. You're fine. Your temperature is 98. And then Deva, in one sentence, summed up my entire research on temperature. He said, "Even if it's 98, you can still be sick." Thank you all so much for this opportunity.
Okay, Dr. Bhavani, thank you for an excellent talk. So next we'll have our 2 original research and 1 clinical vignette resident presenters. Their abstracts were chosen in a very competitive blinded process from over 120 submissions this year. So a big congrats to our 3 chosen speakers. So our first resident speaker will be Dr. Alana Alui for original research. She graduated from the Philadelphia College of Osteopathic Medicine and is one of our PGY2 residents. She's interested in medical education, research, and by the way, is a huge fan of Messi and Argentina. She will be presenting her work on the successful integration of alcohol use disorder treatment into a primary care-based liver clinic. Then our next resident speaker for original research is Dr. Maya Patel. Maya graduated from the University of Arizona College of Medicine, Phoenix. She's also one of our PGY2 residents and will be applying to GI fellowship. She will be presenting her work on lymph node metastasis with small duodenal neuroendocrine tumors and implications for endoscopic management. And then last but not least is our last speaker, Dr. Yusuf Sakwali, for our clinical vignette presentation. After attending the American University of Beirut for medical school, Yusuf joined Dr. Nadine Raphael's team at the Hope Clinic at Emory for a postdoctoral research fellowship in infectious disease. He's currently a third-year resident and will be presenting his clinical vignette, Fever of Unknown Origin. So without further ado, our first presenter.
Thank you so much for introducing us. So I will be talking today about successful integration of alcohol use disorder treatment into a primary care-based liver clinic. I have no disclosures. I've always wanted to talk about One Piece, but today our topic is about alcohol abuse and alcoholism. Sorry, 1 second. Alcohol use disorder, 30 million people ages 12 and older in 2022 were diagnosed with alcohol use disorder, and less than 10% of those people had treatment. 62% of people in the US in 2022 had used alcohol, and 10% of those people had alcohol use disorder. 5 million people who visit the emergency department had alcohol-related problems, and 140,000 annual deaths were related to alcohol. 30 to 35% of heavy alcohol drinkers will develop alcoholic hepatitis, of which 10% will die from liver disease in their 40s. This leads to our study objective. To address the gap of limited treatment for alcohol use disorder at Grady, we created a novel AUD-focused clinic in 2022. This is our Grady AUD clinic. Some of the resources that we provided included motivational interviewing, medication-assisted treatment, and referral to peer and behavioral health support. Starting with motivational interviewing, our AUD clinic physicians and nurse practitioners actually trained in motivational interviewing, and every single visit that our patients presented to, they were asked questions such as, what are your goals in relation to alcohol? What is working well in your current state? And how important is quitting? And how confident do you feel that you can make that change? These are just some of the many questions that we ask our patients. Medication-assisted treatment. Top medication that's prescribed is naltrexone. The pros of naltrexone is that it's FDA approved. Another pro of this is that it's 1 pill daily, great for compliance. The cons of the medication, though, include contraindication. It's contraindicated in chronic opioid therapy, also contraindicated in acute alcoholic hepatitis. This includes patients who have 3 times the upper limit of normal for their LFTs, and it's contraindicated in decompensated cirrhosis. Our next medication, acamprosate. Acamprosate is also FDA approved. The contraindication or the cons of the medication is that it's contraindicated in CKD 4 and 5, and it's also 2 pills 3 times a day. Not great for compliance. Last but not least is gabapentin. So unfortunately, this medication is not FDA approved, but it is an option for those who can't take naltrexone or acamprosate, or who have other comorbidities like peripheral neuropathy or diabetes. Moving on to our referral to peer and behavioral health support. The top peer and behavioral health support that we provide is at the Grady Behavioral Health, and we have coaches that help our patients, whether in groups or single. We also provide them with community resources like Sober Living America, the Georgia Crisis and Access Line, Substance Abuse and Mental Health Services Administration, and many more. So for our clinic, for a patient to be eligible, they needed to have an AUD or audit C score of 4 or more indicating that they have moderate, high, or severe drinking risks. And they also had to be motivated to stop. Referrals were placed by majority were primary care physicians, mainly at Grady, inpatient, 37%, ER and other places like the GI clinic made up 6%. And these referrals were either through Epic or through conferences like these, where we make people aware that you can put in a referral to AUD clinic on Epic, and it's really easy. So we analyzed retrospective data from 2022 and 2023 for patients with at least one AUD visit, and we looked for different things. Hospitalizations 6 months before and after the first visit, treatment modalities prescribed, the percentage of patients taking the medications, and we categorized that into 3 other subjects. How many experienced improvement in their alcohol use, the number of patients with second fills of the medication, and the number of patients with reduced alcohol cravings. Our patient demographics, majority were African American, non-Hispanic male, with a median age of 56.5. And they were equal in terms of insurance status, public, private, and none. And they were also equal in terms of their AUD severity, making up 30% of mild, 30% of moderate, and 30% of severe. And majority, as you can see, were had Grady primary care physicians. And these are our results. So for the number of patients, 30 or 56% of our patients were on naltrexone, 11% were on acamprosate, and 4% were on gabapentin. The number of patients with second fill of medication in the naltrexone group was 80%, and it was 100% respectively in acamprosate in the gabapentin groups. In terms of reduced alcohol cravings and reporting decreased alcohol use, it was 70% in naltrexone and 100% in the acamprosate and gabapentin groups. We also analyzed that 70% of the patients in our clinic had an AUD medication prescribed, of which 68% reported taking them. This takes us to our next result. 6 months before their first visit, hospitalizations for alcohol-related complications was 48%. 6 months after their first visit, this number went down to 13. So in conclusion, our primary care-based AUD clinic leveraged existing infrastructure to effectively treat motivated patients for AUD. Most patients took the AUD medication prescribed, resulting in a significant decrease in alcohol-related hospitalizations. This model could expand access to needed AUD care in similar settings. And something I'd like to say today that came out from ACP, they are also encouraging AUD treatment in the outpatient setting, and they are just released guidelines for it. And so it's becoming more and more prevalent that we should be treating AUD, and we do have medications for it. I'd like to thank Dr. Lom, Dr. Fluker, and Dr. Miller, as well as Dr. Himmerjani, Dr. Armstrong, and Dr. Law. Thank you so much.
Hi, everyone. Thank you, Christina, for that introduction. And thank you all for the opportunity to speak with you today. My name is Maya, and I will be talking about lymph node metastasis with small duodenal neuroendocrine tumors, implications for endoscopic management. I have no disclosures. So some background on the topic. Primary duodenal neuroendocrine tumors comprise about 3% of all gastrointestinal neuroendocrine neoplasms. And the incidence has been increasing over the last few decades, particularly in the setting of improved imaging modalities, as well as increased rate of endoscopy. Prognosis typically depends on the tissue of origin, stage, grade, and differentiation, as well as the functionality of the tumor. But overall, prognosis can be quite good. 5-year survival rate is estimated to be about 95% for well-differentiated duodenal neuroendocrine tumors. There is limited data exploring the differences in patient outcomes between endoscopic management versus surgical resection of tumors, but current studies suggest that surgical approach has no effect on overall prognosis. And this is a figure from the European Neuroendocrine Tumor Society outlining some guidelines on recommended management of these tumors. As you can see, for small tumors less than 1 centimeter in size, as long as they are non-functioning and non-ampullary, it's recommended that endoscopic resection is the preferred management. For tumors that are larger, greater than 2 centimeters, typically they require further workup with imaging, but surgical resection is recommended. And then for tumors that are intermediate in size, between 1 to 2 centimeters, there really is no standardized guideline on whether we should endoscopically versus surgically resect those tumors. Similarly, with the National Comprehensive Cancer Network, our NCCN guidelines, it's also quite vague in terms of their recommendations for how we should approach these tumors. They suggest that non-functioning tumors that are non-invasive, they recommend endoscopic or local excision, but there really are no formal recommendations based on size. Interestingly, the European Neuroendocrine Tumor Society actually just recently came out with these guidelines that are more updated, and these guidelines were released after we initially started this project, but they now state that even tumors up to 1.5 centimeters in selected cases can be resected endoscopically, as long as, again, there's no evidence of lymph node metastasis and they're non-invasive. The guidelines did note that because there's such limited data on the rates of lymph node metastasis and risk factors for lymph node metastasis based on tumor size, it's quite difficult to provide a concrete recommendation for which tumors should be surgically resected. And this is an image I thought was interesting that depicts the endoscopic resection of a duodenal neuroendocrine tumor. As you can see in image A and image C, that's the appearance of a tumor in the duodenum, both on endoscopy and on CT imaging. And then on the right side, you can see that the appearance of the duodenum after endoscopic resection. Endoscopic management has a significant advantage of being low cost, minimally invasive, involving a shorter hospital stay, and having lower rates of postoperative complications. So it's important for us to recognize which patients are optimal candidates for endoscopic versus surgical resection. So the objective of our study was to determine the rates and risk factors for lymph node metastasis of small duodenal neuroendocrine tumors using a large national database. We conducted a retrospective cohort analysis of patients with duodenal neuroendocrine tumors queried from the National Cancer Database from 2004 to 2020. And then we applied exclusion criteria, including metastatic disease, non-initial presentation, as well as any missing covariate information. After this, we conducted a univariate and multivariate analysis to characterize the associations between lymph node metastasis, as well as tumor size, grade, and demographic information. We initially identified 12,651 cases of duodenal neuroendocrine tumors in the database, and after applying our exclusion criteria and removing cases that had missing information, we were left with about 2,244 cases included in our final analysis. And this is a graph depicting the rates of lymph node metastasis stratified by tumor size. In the darker blue columns, that actually reflects clinical lymph node involvement, which is defined as the presence of lymph node involvement on physical exam, imaging, as well as biopsy. Pathological lymph node involvement was defined as the presence of lymph node involvement after surgical resection. And as you can see, overall, amongst all tumors, the rate of clinical lymph node involvement was about 6.68% and higher for pathological lymph node involvement to about 11%. When we stratify by tumor size, those tumors that are small, less than 1 centimeter, only about 3% had clinical lymph node involvement, and about 5.8% had pathological lymph node involvement. For that intermediate size range, we found that 7.9% had clinical lymph node involvement, and about 13% had pathological lymph node involvement. And as you can see, the rates were higher for the larger tumors greater than 2 centimeters. And this graph represents our univariate analysis of risk factors for lymph node metastasis. And these are the variables that were statistically significant: age at diagnosis, tumor size, and tumor grade. In terms of age of diagnosis, we found that for every year increase in the age of diagnosis, there was about a 3% decrease in the odds for lymph node metastasis, and that was statistically significant. We also found, as you can see, with increasing tumor size and tumor grade, there was increased odds of lymph node metastasis. In the multivariate analysis, these variables were still significant. There were only a few cases of poorly differentiated tumors in our study, so that was no longer statistically significant in the multivariate analysis, but the remainder of the variables remained significant. So in summary, duodenal neuroendocrine tumors less than 2 centimeters in size had a rate of clinical lymph node involvement of about 5.4%. And moderately and poorly differentiated tumors that were larger in size were expectedly associated with higher rates of lymph node metastasis. Given the relatively low rates of nodal involvement amongst duodenal neuroendocrine tumors that are less than 2 centimeters in size, these small tumors may be considered for endoscopic management, especially for patients who are not ideal surgical candidates. That being said, the rate of lymph node metastasis was not 0%. So further workup to exclude lymph node metastasis, for example, with imaging, may be warranted in some patient populations. And our NCDB database did not actually differentiate between endoscopic resection and local excision, so we couldn't directly compare patient outcomes between these two forms of management, but future research examining outcomes of endoscopic versus surgical resection may further guide this management. Thank you to Rishi Das and Dr. Willingham for all of their support and guidance. I'd also like to acknowledge the biostatistics and bioinformatics shared resource at Winship Cancer Institute at Emory, through which we were able to access this database. And these are my references. Thank you all.
Hello, everyone. I'm Yusuf. I'm an internal medicine resident. I'm interested in clinical reasoning, medical education, and storytelling. This is my clinical vignette. Because of my interest, I will try to bring out my teaching points throughout. I also work with the Clinical Problem Solvers, a group that focuses on clinical reasoning. I'll be joining the Division of Hospital Medicine in less than 3 months. Jumping into the case. This is a 59-year-old gentleman presenting for fever. This is a journey of 40 days. And the journey starts on day 1. I urge you to think through this case with me and think about the differentials or what's going on with this patient. He has a history of lupus, end-stage renal disease, and a renal transplant. Unfortunately, the transplant had failure and he was receiving hemodialysis via left upper extremity AV fistula. He has a history of bladder cancer with intravesicular BCG 2 years prior. He also has severe aortic regurg with a mechanical valve 10 years prior as well. His home meds include prednisone and tacrolimus. He lives in Georgia, works in a department store, has no pets, no outdoor exposure, no recent travel, has been to Germany in the 90s, and has not consumed raw meat or unpasteurized dairy products for the ID enthusiasts out there. A 12-point review of systems was negative. The physical exam was normal, essentially. He had a high-grade fever to 39, but no focal infectious findings. So what is your problem representation at this point, and what is the etiology of fever in this patient? So in general, my problem representation is this is an immunocompromised gentleman with a history of lupus presenting for an acute episode of fever. And this is the timeline on day 1. The initial white blood cell count was elevated at 17,000. And the liver enzymes were slightly elevated with an AST of 107 and ALT of 89. Blood cultures returned positive for strep sanguinis and the patient was started on ceftriaxone. What is strep sanguinus? It's a gram-positive cocci. It's a viridans group strep. It's part of the human oral flora, and it's what we call sticky. It basically is a common cause of subacute endocarditis. This is a gram-positive cocci in chains. So in terms of workup, the patient was persistently febrile to 39 degrees daily, even despite repeat cultures that were negative. We thought of possible niduses of infection, including his aortic valve and his AV fistula. A chest X-ray was clear. An ultrasound of the AV fistula was negative. A right upper quadrant ultrasound was normal. That was done because of the elevated liver enzymes. And the patient had persistent daily high-grade fevers. On day 4, vascular surgery and infectious disease were consulted for further workup. And just to recap the case, this is a moderately immunocompromised gentleman presenting for strep bacteremia, now with persistent high-grade fevers. A TTE and a TEE were negative for any vegetations. The HIV and the hepatitis panel were negative. A ANA and the complements levels were normal. The Brucella, Bartonella, Coxiella, the causes of culture-negative endocarditis were also negative. So were the fungal serologies and antibodies. This is day 12, and the patient is still having high-grade fevers throughout. And on day 14, a repeat TEE was also negative, and a tagged white blood cell scan showed uptake in the lungs. Now, what is a tagged white blood cell scan? It's similar to a PET scan, but instead of they use white blood cells to try to localize infection. Although one retrospective study showed a high positive predictive value, but a low negative predictive value. And my teaching point is that although it may be helpful to localize some infections, it is not sensitive enough to rule out infection in general. So why not just get a PET scan? Well, one meta-analysis of PET scans showed that it does have a higher sensitivity in FUO, up to 85%, and could potentially reduce cost. However, it remains very costly, and it is system-based. It might be easier to get in one hospital compared to other hospitals and so on. Back to our patient. The tagged white blood cell scan showed uptake in the lungs. CT showed a cavitary right upper lobe nodule with diffuse ground glass opacities. Pulmonology were consulted, and they helped with a BAL. All the BAL cultures were negative, including a TB PCR. A biopsy of the nodule showed necrotizing granulomatous inflammation. And this is at day 18 with persistent daily high-grade fevers to 39. On day 20, the patient's blood count started to drop. The hemoglobin was dropping slightly. The platelet count was as well. The ferritin was elevated. The triglycerides were elevated. Does this pattern bring anything to mind? Well, it's hemophagocytic lymphohistiocytosis. The criteria for diagnosis are on the right. You need 5 out of 8. But and one tool to use is the H-score. It's a calculator on MD-Calc, has a high sensitivity and specificity to help diagnose HLH. Also, it can help you remember all of those criteria. However, my teaching point is that HLH is primary and is oftentimes secondary. The HLH committee that met in 2019 published a paper that says an HLH pattern can be caused by infections, malignancy, or rheumatologic disease. Therefore, HLH is a very specific type of inflammation. Similar to lymphocytosis that takes you in a specific diagnostic pathway, HLH should take you in a specific diagnostic pathway, especially if it's secondary. And this is a schema by the CP solvers that shows different causes of HLH, which includes some viruses, lupus, RA, and lymphoma. The FDG PET was performed on day 23, and this showed an active fluid collection in the hip. This was aspirated, and all the cultures were also negative, unfortunately. And note that this was not seen on the prior white blood cell scan, but it was seen on the PET scan. And on day 30, we finally get a break in the case. We get a page from the microbiology lab, and the AFB cultures from blood were positive for MTB complex. MTB complex includes a variety of organisms, including Mycobacterium tuberculosis, but also includes Mycobacterium bovis and the BCG strain. What is M. bovis? And we were wondering where this potentially could have come from. It's likely from his BCG therapy 2 years prior. Cultures from the lung, the abscess, later also returned for positive for MTB complex. And the patient was initiated on the appropriate antimicrobials with the resolution of the fever. MTB and M. bovis are indistinguishable. They cause a similar syndrome. This can be acquired by drinking unpasteurized milk. It's a common vignette. If somebody has sterile pyuria, but no organisms on culture, it could be M. bovis if they have exposure. And intravesical BCG is a common therapy for superficial bladder cancer. This syndrome is termed BCGiosis when the BCG disseminates. The BCG is instilled into the bladder. This is a form of immunotherapy, and this helps with that malignancy, helps the body fight it. But rarely it disseminates, and it can go to various sites in the body. And this is the syndrome called BCGiosis. Reactivation can occur years later after this therapy, sometimes after vaccination as well. And the safety of intravesical BCG in immunocompromised individuals is still unclear and should be further evaluated. Finally, this is the end of the timeline, fortunately with the resolution of the fever. This is a recap of my teaching points. In general, tagged white blood cell scans are not sensitive, may be helpful in some infections. HLH is often a secondary diagnosis. You may use the H score. Lastly, Mycobacterium bovis behaves like TB, can be acquired through unpasteurized milk or BCG and may disseminate years later. And that syndrome is called BCGiosis. Thank you so much. This is my dad. These are my parents in Southern Lebanon and my grandparents. If you have any feedback for me, this is my barcode. Thank you.
Okay, once again, thank you to all our speakers. And so we'll open up questions for chat, or please raise your hand on Zoom. Oh, wow, this is quite a few already. All right. Yeah. Oh, okay. So any questions in the audience from chat, or you can raise your hand as well. Yeah, I can. Oh yeah, you said we.
From the audience is to Yusuf, what do you make of the strep cultures in your case?
We thought about this a lot actually. Like, what is the relevance of the strep cultures? We were wondering if the strep cultures were a trigger for a temporary immunosuppression. In addition, when the patient had the strep infection, the team did not want to keep on the immunosuppressants as well, given that they're having bacteremia, and wondering if the level of immunosuppression modification after the bacteremia led to dissemination of the BCG. And we thought about that a lot. This is what we thought about, but I don't think we have any other thoughts about it. Yeah, and that's what we thought as well with Dr. Fatke and Dr. Abdullah.
So I want to thank everyone, for all the presenters. Great. I really appreciate the commitment to research by the residents. I want to really thank everyone for these great presentations and look forward to the posters this afternoon. I think one message, overall message, is you've got to continue to be learners. half of what you learn now or did learn is probably wrong or will change. Certainly, that's my experience. I grew up with peptic ulcer disease as being acid and acid only, and that wasn't the case. And obviously, it took research to change that paradigm and change it significantly. So just a reminder that there are a lot of you need to continue to question the facts, if you will. So always do that. I had some questions about the sepsis presentation. I just wanted to. I was fascinated about an article that suggested that the microbiome contributed to fever or contributed to temperature regulation. Could you comment a bit on that? That was interesting and wanted to learn more.
So this is embarrassing because I don't have the details of that article, but in general, what they found was in a mouse model as well as a human model, the temperature patterns that emerged were related to the diversity profile of the microbiome. And microbiome is one of those, I feel like, catch-all things that is kind of intersecting with all of the different types of research that we do. But that they're finding that was one of the independent lab groups that used the temperature trajectories, applied it to humans and mice, and then found that there was like separation in the diversity profiles of the microbiome.
And in your study looking at cohort D, vital signs associated with cohort D, which I really didn't understand what those vital signs were. Could you elaborate a little bit more on cohort D and how that appears to be, how crystalloid appears to benefit or not in those individuals?
So group D, so the 4 groups are defined by their vital signs in the first 8 hours of presenting to the hospital. Group D happens to be those that are hypotensive, but don't seem to have a like classic SIRS response. They have lower temperatures, heart rate, and respiratory rates than most of the sepsis patients we see with hypotension. So that's kind of the broad description of the group. Again, these are patients that on visual inspection, it's hard to kind of place them in one group or the other. And the algorithm kind of looks at the distance from each of those trajectories. The second part is why do they benefit from balanced crystalloids? We actually don't know the mechanism of that. And part of that is, I kind of see a lot of these like big data studies show the description of what we find. But then the next step is like, what is the mechanism of why there would be a benefit in this group from balanced crystalloids versus normal saline?
Everybody, can you hear me? I see Dr. Del Rio plugging for infectious disease up there, so I felt it was only proper to get up and say something about GI. So, so I just wanted to say my great job with your research. It's very hard to work with a 12,000 patient database, and especially when you probably haven't had any training in biostats and epi. So brilliant job. The surgery in this case that she mentions is a Whipple, which is a very big deal for someone with a 1 or 2 centimeter neuroendocrine tumor. So I think her research is outstanding and hopefully will save a lot of patients a huge surgery.
Hey, this is a question for Dr. Alui, who happens to be sitting right behind me. I feel like I saw in one of your slides that, at least in my mind, paradoxically, the medications that had the most benefit for the alcohol use disorder were the ones that had the highest risk for lower compliance. And I just wanted to see if you could comment on that and or what we should be prescribing, because I've been doing this a bit more and more in my practice, but I don't want to be prescribing the wrong thing. Obviously, getting people to a clinic is the most helpful, but just want to hear your thoughts.
Yes. So granted, we only had very few patients who were on acamprosate and gabapentin, so it's hard to actually say. Maybe if we had more patients, more like a larger N, it probably would have been the same. Naltrexone is easier to take. Gabapentin, the only reason that a lot of people are already on it is because they were probably on it prior. It's one of the medications that everybody gives out to our patients. And so they're used to taking it. Acamprosate, I honestly don't know. But acamprosate, we didn't have a lot of people on it. Whereas naltrexone, we had a larger population that was on it, like 30 or like more than half of our patients were on it. So sorry, not a great answer, but maybe if you had a bigger N, we'd have, yeah, more to come.
So, oh, okay, thank you. So I say it's 1 p.m. now. So that concludes our grand rounds for today. And just one final reminder that our poster session, again, is from 4 to 6 p.m. in the Emory School of Medicine lobby. So please drop by, enjoy some great research and some light refreshments. So thank you, everybody.